Tonight, I have the pleasure of introducing Dr. Almeida, and if you'll hold your questions until after he's done with his talk, he'll be happy to answer your questions. But in the meantime, let him go ahead and finish his presentation. Dr. Almeida graduated in the top of his class with honors from the Chicago Medical School in 1991. He completed a residency and fellowship in nuclear medicine at the University of San Francisco and is certified by the American Board of Nuclear Medicine and the Certification Board of Nuclear Cardiology. He was in academic practice at the University of San Francisco and private practice until the year 2005. Dr. Almeida is one of the pioneers in the development and the implementation of cross-modality fusion for prostate cancer imaging. That goes with SPEC, PET, CT, and MRI, and PET/CT, which we've all heard of. We don't understand it, but we all understand. Dr. Almeida understands it, so he'll tell you about that. In 2005, Dr. Almeida joined the University of Arizona, and while at U of A, Dr. Almeida led the creation of the first combined PET-CT imaging program in southern Arizona and established the routine integration of PET-CT image into radiation oncology planning. Dr. Almeida is the medical director of the Southwest PET-CT Institute and Arizona Molecular Imaging Center, and oversees clinics in Tucson, Phoenix, Yuma, and then he came west to Indian Wells. Providing his extensive clinical expertise in PET-CT imaging. Tonight, Dr. Almeida will give an update on carbon-11 acetate, PET-CT imaging of the prostate. Men treated with prostate cancer often have the reoccurrence of their cancer. And that is difficult to find with an elevation of PSA and no evidence of reoccurrence on standard imaging tests, i.e. your normal CT scan, ultrasound, MRI, and bone scans. This can be very frustrating for both patients and treating doctors. And deciding on the right treatment is then difficult if you can't see what you're treating. And many patients are submitted to incorrect treatment. Carbon-11 acetate PET-CT imaging is a molecular imaging study that is under investigation at the Arizona Molecular Imaging Center, which is able to help this situation. In other words, he can see things that other scans can't, the traditional scans cannot. Additionally, Dr. Almeida will discuss other imaging agents in development to help with prostate cancer. Dr. Almeida spoke to the Forum Support Group on this topic last year, but it was just in the beginning stages. I mean, it was beginning stages to us. He'd been at it a couple of years. But now he's returning to discuss further results from his ongoing study, and now has over 500 patients, including a couple of you that are here tonight, including board member Larry over here. So, without any further ado, I would like to present to you, and the Prostate Forum of Orange County presents to you Dr. Almeida.
For that wonderful introduction. So as Russ said, we're going to talk a little bit about subsequent results with this particular scan, but I did want to kind of get a show of hands for those who were here last year,
There you go.
and where this is going to be a review. I don't want to spend too much time telling you something you already know. How many have never heard of carbon acetate or PET imaging? Okay, so we're going to go through some of the basics on this, but part of this talk is also going to be about some other molecular imaging agents, things you've probably read about or heard about, to put them in perspective. And then it's kind of a cumulative Q&A that I get at imaging conferences, where what about MRI for this, what about choline, what about FACBC, some other things that you can see in the literature, and kind of where the state of the art is going with this. Okay, so as Russ had mentioned, we have a challenge with recurrence of prostate cancer. We focus on this particular area with molecular imaging because our standard imaging actually does so poorly. So CT scans, bone scans, MRI, we particularly depend on size for MRI and CT. So lymph nodes and lesions have to be a certain size before we're confident in calling them positive, which means that they have to be quite large and quite numerous for us to have confidence that there's recurrent disease. And PSA is quite high by that time, and we don't like to wait until we can see them before treating it. So with the issue of prostate cancer, within 10 years, about 30 to 40% of patients do have a recurrence. I think that number is going down, but it's still up there, and it doesn't matter whether it's after surgery or radiation or combination. You do see quite a few people have these issues. Okay, so I'm going to run through a few of the standard techniques and some other techniques that people will probably be familiar with, and mostly just to kind of run through the names. So you heard PET, CT, and MRI, and so just kind of get through the nomenclature, because we have a lot in imaging, like any other field, and we throw them around without always defining them. So CT, computed tomography, very much a workhorse that we use for imaging, very quick and easy to do. It's three-dimensional imaging that's x-rays going through the body, done in a tube. Very good for picking up all sorts of things, infections, fractures, and also a lot of cancers early on, depending on where they are. But when we're talking about prostate cancer in the case of recurrence, we're having to really look for the lymph nodes early on, and even things in the bone can be missed on CT scanning because we need to have a fair amount of changes happening in the bone as a consequence of the cancer for us to see it. So not the best technique, probably no better than about 50% for a lot of the issues with prostate cancer. So MRI, so magnetic resonance imaging, very good technique for looking at small structures and anatomic structures of the body. For the prostate, probably still the best test for us to get a good look at the prostate. You can see the anatomy and all the different architecture of the gland very well. But we do have some issues with certain parts of the gland are harder to see than others. The central gland, for example, on MRI, can still be problematic. When I say hard to see, what it comes down to is, can we identify a focus of cancer and be confident that it's cancer and it's not normal or some other benign thing? So being able to differentiate cancer from other things. It's also very good at looking at the surroundings of the gland, so the capsule, and so we can see whether it's extended out of the gland and also into the adjacent seminal vesicles. So very good anatomy. But even with that, a general MRI, probably its sensitivity is only about 75%. So very small lesions still can be missed, and depending on where it is, it can also be missed. We have an addition of multi-parametric MRI, adding additional sequences where we look at water molecule movement or we look at blood flow, and it adds additional information to evaluating the prostate gland, and it adds some sensitivity as well as specificity. So when I say specificity, I should define the sensitivity. Can we actually see something that we think is abnormal? And hopefully we're right. The specificity is how often are we right? So that something can be very sensitive. We think we see something that's abnormal and we're calling it cancer, but it may actually not be cancer, and that can affect its specificity. We like both of these to be very high. Unfortunately, we don't have too many tests that are that way. Enhancement to MRI is Combidex and ferriheme, which is an iron particle that goes into the lymph nodes. It's bright on MRI, very easy to see very small lymph nodes. And when we use this agent, inject it in, if it does not go into a particular lymph node, we find that to be suspicious for cancer. This is done only really in two places I know of ferriheme. In Florida, Combidex was being done in the Netherlands. fell out of favor, didn't get FDA approved, but is now again being done in the Netherlands. There's some issues with this as far as safety. Could be a problem if it's not done correctly. So we have had patients have serious reactions to it. And even when we look at it in its best case scenario, it's positive predictive value. So when we say the test is positive, how often is it actually cancer there? It's about 75%. And so the false positive rate, it says it's abnormal, but it's not actually really cancer. It's a little higher than we'd like to see it. These were probably the root reasons why it didn't get FDA approved back in, I think it was about 2007 when we saw that. Okay, so standard bone scan, technetium-99, MDP scintigraphy. So this is methylene diphosphate. This is a bone seeker. So we tag, essentially like tagging calcium. We tag calcium with a radioactive material. It goes into the bone very quickly, and it's a very good marker of something going on in the bone. So bone repairs itself in response to trauma, to fracture, and also in response to having cancer. It is a two-dimensional imaging study, so we're looking from front to back. We kind of take angles from that. And it is a very sensitive test overall, but the problem is, particularly in older gentlemen, we have arthritic changes, we have old trauma, we have life that we have to look through in the spine, and it can be very challenging sometimes to tell the difference between normal things in certain joints in the spine from cancer. So can be a real problem. It also, the technique, because of the agent that's used, technetium-99, and also the kind of camera technology, which is a gamma camera technology, realistically, we can only see lesions down to about a centimeter, centimeter and a half, which isn't big, but we'd like to see things in the bone that are in the millimeter range in order to catch them early. The reason I bring this up is because we really have shifted to another bone scan, which is a PET-oriented one that I'll talk to, and then I'll come back to prostate. So sodium fluoride PET-CT, so PET is positron emission tomography. It's combined with CT, and this is essentially another bone seeker. So it's very similar to this technetium, but it's a higher energy isotope. We can use a three-dimensional, much quicker imaging to look at it, and much more accurate as far as being able to tell the difference between joint and the bone marrow and what is and what isn't cancer, which is really the idea. But it still is looking at bone reaction to cancer or bone changes. So we still have to be careful about particular patients who have had previous treatment, whether it's hormonal or radiation therapy. Bone scan can stay positive for a long time, even if the cancer right around it is no longer there. I'm going to show you some examples of these and comparing it to the other bone scan. So Prostacint is an agent that's been around for a while. It is an antibody that is tagged with indium, and it is directed to the prostate-specific membrane antigen. So there's a protein that prostate cancer cells make that we have an antibody against. And so the theory being that we've got a very precise tag for looking for prostate cancer. I did a lot of work with this a decade ago, and somewhat disappointing on a couple different levels. The agent itself, because it's an antibody, antibodies are big proteins. It takes a long time to clear out of the normal areas, particularly blood pool. So that we would inject this agent, we wait 3 days, 2 or 3 days, we start the imaging. We have to combine it with MRI, combine it with CT scans, combine it with a blood pool imaging, quite complicated. And I think even in the best hands, our accuracy or our sensitivity was only about 63%. So other attributes of it, generally we needed the PSA to be about 6 to 10, and realistically, we weren't going to see some very small things, less than 1 to 2 centimeters. So from an imaging perspective, this didn't add a lot to our standard imaging, because we still needed things to be pretty big, and we had to wait until the PSA was fairly high. So a few places still do Prostacint, but I discourage it, and I think we're seeing less and less of it. Okay, so we're going to spend a lot of time talking about acetate, but I wanted to contrast it a little bit to choline, and we're going to talk a little bit about that also later. But carbon-11 choline, carbon-11 acetate, they're very similar in what they do. We're imaging increased metabolism in prostate cancer cells. with these agents getting incorporated into the membrane, the outer part of prostate cancer cells. It's part of a normal metabolic pathway, so choline and acetate, they're agents that we eat, we ingest all the time, we need them as part of our bodies. And with prostate cancer, we know that there's an upregulation of the enzymes responsible for bringing these in. Carbon itself is a little bit of an issue in that it has a very short half-life. So it's good for patients, and then we inject it, it disappears very quickly, so the radiation is very low, but it means we have to, when we make anything with a carbon label, we have to use it right where we made it, and we've got to be very quick about it. So a delay, any significant delay means we're losing our dose. Contrast that to F18, which we talked a little bit about with the bone scan. A fluoride label, that's 110 minutes. There's cyclotrons across the country, make tons of this stuff, or I should say curies of it, that's the right measurement. So when we look at choline and acetate, one of the things that we've been able to establish is that they're both pretty good once the PSA is a little higher, certainly above 3. But when the PSA is lower than 3 and getting down into less than 1, the acetate seems to perform better. Overall performance rate has been higher on the acetate, and I'll get into some detail with that. So some other agents that you'll run across being talked about, now there's a new generation of PMSA agents, so this prostate-specific membrane antigen, and it's small molecule proteins and other ligands that are much smaller than an antibody that was associated with prostascent, labeled to gallium-68, which is also a PET tracer. So it's something we can use PET imaging, the high-end imaging for, and it's a fairly specific target. Very exciting work being done in Germany on this. I think there were at least half a dozen, if not more, different PMSA agents being presented at the Society of Nuclear Medicine meeting last month. And all very exciting, very early work being done. A couple advantages of it is with prostascent, the antibody was tagged against the part of the protein that was on the inside of the cell. So the molecule had to get pulled into the cell and attached to the inside of the cell. These agents are being looked at as part of the protein that's on the outside of the cell, so it has more access, and we expect these to do pretty well. Issue is gallium-68 is a challenging agent. It's not made by a cyclotron, which is our standard way of making these agents, but done with a generator. And there is no FDA approval in the United States for using gallium-68 generators. And so we got to do that first before we can do something that's combined. And we've been talking about gallium-68 in the US for probably a decade, and we haven't seen it. So Germany definitely has an advantage in this, and we're going to be looking to see how well this thing performs over time. That may drive us to be looking at this more seriously. There is a version of choline that has a fluorine label, which we like because of the half-life, longer half-life, which means we potentially could make it in one place and ship it out to wherever it needs to be used. One of the issues with something that is labeled with fluorine is invariably it gets excreted out in the urine. So we end up with a lot of it in the bladder and a lot of it in the ureters. And when we're dealing with prostate cancer, it's kind of our target. We're right there by the bladder. If there's interference from hot activity that's normal in the bladder, we're going to miss things. And so we know that with this agent, which is being used a little bit in Europe, it drops off about 30% of our detection rate right off the bat because of its urinary activity. Okay, so the last agent here, this is an amino acid that has been worked on at Emory University. It's, we'll not go through that whole long name. FACBC is the name of this agent. It is labeled with a fluorine, and this is an altered amino acid. So it's like leucine, which is one of our amino acids, but the configuration has been changed. And we know that it also gets taken up by prostate cancer cells. So the transporters for that prostate cancer are upregulated, and it has the advantage of the fluorine label. And so far, we're seeing that it has very little urine excretion, which is a real plus. So this is in early studies now. It has a lot of promise to be potentially the kind of the winner of all of these as far as getting to being able to do high-end molecular PET imaging with an agent that we can have everywhere, okay? Which is not the case with the carbon acetate, which is what we've been working on for a number of years. And this has to be done in our facility or a facility that's equivalent to ours, like Kansas University, or you have to go to Mayo Clinic in Rochester to get the choline. So the carbon label really makes these difficult to access. Okay. But one of our tasks, of course, is going to be, let's make sure that if we're going to use an agent like this, that it's at least as good as what we know we're getting with choline and carbon acetate. Okay, so positron emission tomography. This is what the camera looks like. It is a combined camera of PET camera in line with a CT camera. And the PET camera, this is essentially a crystal structure in a circle that allows us to detect radiation very precisely. The agents that we use for positron emission tomography have a high enough energy and a particular way that they decay, that they annihilate and produce electrons that go off in opposite directions. So when we have things that do that, and that's a positron emitter that does that, we can localize things in 3 dimensions, which we can't do with our other agents like technetium. It's combined with the CT scan, so we can map the body. The CT gives us what's called attenuation correction, and so I know what's bone, I know what's lung, I know what's fat, and because they have different attenuation of how they move a radioactive particle, how they bend. And we combine it with that, and the side effect also is then I also have a high quality anatomic image from the CT that I can directly combine with the molecular imaging. So we kind of get the best of both worlds of anatomy and physiology or metabolism. Okay? It's a painless procedure, other than we put an IV in, do an injection. The agents, whether it's the standard agents, fluoroglucose, sodium fluoride, acetate, choline, no side effects, no reactions. They're very, very safe agents. So real advantage. When we do an imaging study, it's about 15 to 20 minutes on the camera. So it's very tolerable. Okay, and the reason I bring that up is those of you who have had extended MRIs know MRI is a good technique, but if you do a lot of the body parts, you can be in the MRI tube for hours. And it's one of the reasons we don't tend to do whole body MRI, because people don't tolerate it very well. Okay, so here's an example. This is a technetium bone scan, very standard, front side, back side, looking at the whole body. And in this particular gentleman, his PSA is 0.8, so it's quite low. So this is a gentleman who has recurrence. He had a prostatectomy, and now we're seeing recurrence some years later. And there was this little spot here that was on the technetium scan. This is on the back side, looking at the left side. And this was read out as probably just arthritic changes in the joint. That's a very, very common read. And based on this image, you can kind of go either way. And the fact that it's kind of pushed off to one side rather than the center does tend to say, well, it might more likely be in the joint just from the location. So we did a F18 PET scan. So this is what a sodium fluoride PET scan looks like. It's a bone scan, 3-dimensional, and combined with the CT. And we were able to see that that lesion that was thought to be in the joint is actually in the bone marrow in the back part of that bone. And we're also able to pick up a very small, just a couple of millimeter lesion a little further down. That's where these 2 areas are. And up here, this is the, here and here, that's the normal urine in the kidneys, and here's the bladder, very hot. So it's a study that we're able to see much more with a very low PSA, and I would argue that most urologists would not even consider doing a bone scan with a PSA of 0.8. This kind of bone scan very, very seldom yields positive results or accurate results until the PSA is much higher. We're routinely seeing positive results with bone scans with PSAs less than 1. And so that's a fairly significant change. Okay, so here's another example. Now this is a patient where this is the front side, this is the back side of a technetium bone scan. We did see something here in one of the vertebrae. It looks like it's in the body of the vertebra, so more convincing that there is indeed something there that looks like a metastasis. Fairly high risk. So this gentleman has not had anything done yet. Gleason of 10, PSA of 11, so not fairly high risk, high risk. That's the worst Gleason score you can have. And but the interpretation was possible lesion in L3. So we did a sodium fluoride bone scan. And you can see this is that lesion. This is the vertebral body here at that level. Clearly there's a lesion there. It's in the bone marrow. It's nowhere near the joints. Very convincing. But this scan also showed a number of other lesions. So a lesion in another vertebral area, a lesion in the pelvis. So this is the right side of the pelvis here. Very subtle lesion here in the lower left part of the pelvis. This is the ischium. You can see it a little bit better here. And also rib, and I think there were a few other lesions. So really the idea on this, if we're going to do a bone scan, and this is something that's been coined by one of my colleagues, one of my urology colleagues, that says if you want to find what's going on in the bone, you do an F-18 bone scan. If you don't want to find it, you do the technique bone scan. Which, I mean, obviously that's a gross exaggeration, but I think our ability to be accurate and also come up with results that are much more definite. So my confidence in the F-18 sodium fluoride bone scans is much higher. I've read thousands and thousands of techniques in bone scans, and when I see a lesion that I can't make my mind on, I have to throw out there, well, it could be degenerative or it could be metastatic. That's not very helpful. But we're put in the position of having to say that because we can't decide based on the information we have. I very rarely have that issue with these kinds of scans. Usually it has to be someone who's got rods and a lot of surgery, race car drivers, fractured almost everything, and then we have a challenge. Okay, so this gets into the metabolic pathway of acetate. So this is a representation of a cell, and acetate gets pulled into the cell. And one of the things that we know about prostate cancer is this enzyme, fatty acid synthase, is upregulated. So this is working overtime. And we're able to take advantage of that. It pulls in more acetate and deposits it into the cell membranes. We also know there's probably some washouts so that it doesn't go in there and just lock in. Some of it's getting metabolized and getting expressed out as CO2 from these cells as well. So this is the metabolic pathway that we're taking advantage of. I'm going to show you some examples of the carbon acetate study. So this is the cross-section of a CT. This is with the carbon acetate overlaid on it, and it's represented in the red. Here we're looking at the pelvis and cross-section. Here we're looking from side to side. Here we're looking from front to back. So this is the patient's front side. This is the back side. Here's the right, and here's the left. These are the bones. Most of these are muscles. This is the rectum. And this structure here, this is the prostate gland. So this is a gentleman who had a Gleason 7 disease with a PSA of 6.8 when he was diagnosed. He had external beam radiation therapy, had a good result with that. His PSA dropped to 0.4. And this was 4 years before this scan. And now his PSA was 3.9, doubling a little bit less than 2 years. So with this scan, we were able to see there's an area on the right side of the gland that's clearly taking up the carbon acetate. This is a pretty typical appearance that we see with this. One of the advantages with molecular imaging is it's hotspot imaging. So we look for the areas that stand out against the background. And the agents, we hope they're very specific to what we're looking at, or at least looking at the cells we're looking at. As opposed to, for example, when we look at a CT scan by itself, it's a lot of different grayscale. So it's more challenging to see small structures, even if we use contrast and whatnot. It's a more difficult exam to get through and have the accuracy because you're going to miss small things. And you kind of have what's called a little grayscale overload. So being able to represent something in color, they kind of pop out at us. So it's one of the reasons that PET is as popular as it is it's an easier scan to read. We have a higher accuracy with it. So what was important in this particular gentleman is not only did we see this area here in the prostate gland, but we didn't see anything anywhere else. So no lymph nodes lit up, nothing in the bone, nothing in the lungs, so everything else was negative. This was biopsied, and it was proven to actually be a recurrence. And he decided to undergo salvage brachytherapy, so radiation therapy seeds were placed in there, and his PSA on follow-up with no other therapy has been 0.2. So a very good result with this. Okay, so another example. This is a gentleman Again, same thing at the pelvis here, the right side, left side. This is the rectum. This is a clip from surgery. He had had his prostate removed 11 years previously, so RP being radical prostatectomy. Gleason of 8, PSA of 4, and he had a very good result. His PSA essentially went undetectable, but it did start to come up, and at the time of the scan it was 3.3, a little under a year as far as this doubling time. And we're going to get into why I'm going to talk about doubling time as well as the actual numbers here, because they do matter. So we saw this focus here in the prostate bed. Now this gentleman was set up to potentially undergo radiation therapy to the prostate bed as a standard of care. And this imaging was done to make sure there was nothing else going on and see if we could actually find the focus. So we did see a very clear focus here in the very bottom part of the apical prostate bed and nothing anywhere else. And with this focus here, the treatment that was actually delivered was a little different than the standard radiation. Because we were able to identify this, the radiation oncologist designed the radiation therapy field to be more focused on this and to lay off everything else a little bit. Still covered the whole area like you normally would, but it changed how he delivered that radiation because we had a target. We call that dose painting, and it's not something we have done a lot of with prostate cancer, but I think there's a trend that if we can identify a target, the techniques with radiation oncology now, we can hit that target. So why do a big swath when we can narrow it down? So this gentleman underwent radiation therapy, and follow-up, his PSA had gone down. Again, on no other therapy. Okay, another example. This is in a gentleman who had external beam radiation therapy. We've seen a recurrence here in the right side of the gland. His PSA, when we saw him, was 2.9. Again, about a little under a year. Interesting for him is that he had had a processing scan that said that he had multiple lymph nodes that were lighting up in the chest and the abdomen. So initially he was going to be a candidate for any kind of focal therapy. So there was a question of whether the processing was accurate or not. When we did this scan, we only saw this area light up, no abdominal nodes, nothing in the chest. So the processing was a false positive. So he was able to undergo additional therapy. He chose cryotherapy to this area. And again, no other therapy other than the cryotherapy. And this was done by Dupont in Ventura. He did a hemi gland, so he did just the right side here. And the PSA has stayed undetectable up to this point. Okay. So the reason I showed you kind of three similar cases, all in the prostate, is they had very different treatment modalities to go after them. Radiation, external beam radiation, brachytherapy in one, and cryotherapy. And they probably could have all been interchanged to a certain extent. And so what we find with these imaging is it provides opportunity for other focal therapy, narrows the choices down, but there's still choices. And that can, depending on who you're seeing, what their expertise is, and personal preference. Okay, so here's an example where we're looking at the seminal vesicles here. So this is the bladder here, the urinary bladder. Here is the rectum. Again, the front, back, right, left. And this is the left seminal vesicle, and this is the right. You can see there's a very bright area here in the right seminal vesicle. The patient had an MRI. We didn't see anything on the MRI. So this was a new finding. Gleason of 8, PSA of 4.8 when he was diagnosed. He had extracapsular extension positive margins at that time. So seeing something in the seminal vesicle is not entirely unexpected. PSA at this point, though, was 0.5. Doubling time is about 3.2 months. So very low PSA, but it's moving quickly. And that's really one of the things that we're finding is that when we're able to see things with a very low PSA, but usually when the doubling time is moving along. So there has to be a certain momentum to the metabolism that we're going to need. He actually underwent radiation therapy to this area. Also, there were no other lesions. Okay, this is a pretty typical pattern of what we see with the lymph nodes. So we're a little higher up in the pelvis. So this is the pelvic bone here. The white here, this is the intestines. We give everybody a little barium to drink so I can see the intestines. These are muscles here. These are the blood vessels. And there's this area here that is lighting up. And this is a lymph node that is rounded, but it doesn't meet our criteria for calling it positive on the CT scan by itself. Or we would call it suspicious, I think, at best. With the carbon acetate, we're very confident that this is involved. And this gentleman had had brachytherapy, external beam radiation therapy to the prostate previously. He had a decrease in his PSA. PSA at the time of this scan, a little over a year. He elected to have a salvage lymphadenectomy, so removal of lymph nodes from both sides of the pelvis. And what was found was he had 13 nodes removed, 1 node was positive, directly correlated with this. And I don't think you can read this at the bottom here, but his PSA dropped to undetectable right after surgery. This is salvage lymphadenectomy, so going in after some other therapy, just take out the lymph nodes. A little bit controversial. I know some surgeons who really aren't very interested in doing it, and others that are doing it routinely. It seems like it's got some momentum in Europe, and I know a few people across the country who do it at the drop of a hat. So I think our standard, more often than not, is to do radiation to those areas because we can get a little bit broader coverage, a little higher up. But the idea is if we're getting rid of the nodes either with radiation or surgically, we're accomplishing the same thing, getting these gone. Okay, so another example, very bright lymph node, also in the same part of the pelvis. And this one really should not have been missed. It is enlarged, but you can see on the CT scan here, and this is without contrast, but even with contrast, this was hard to see. You can see it just kind of meshes in with the blood vessels and the surrounding structures. Extremely easy to see with the carbon acetate. This is a gentleman who had a prostatectomy. His PSA at 9 months was just starting to come up. So pretty quickly after surgery, and the thought was there was likely something in the prostate bed, maybe had left behind, or just positive margins. And he did have extracapsular extension. He had both seminal vesicles involved. So high risk for there have been some disease left in the prostate area. So he was scheduled to have salvage radiation therapy to the prostate bed. With this lymph node being identified, that was altered to the prostate bed plus the lymph node. So it was extended to include this lymph node as well as the lymph nodes on both sides of the pelvis, all the way up to the top of the pelvis. So the information on this scan really changed how his radiation was delivered. Okay, so prostate itself, the prostate bed, as well as lymph nodes, carbon acetate is very good at. Also looking at the lung and lymph nodes elsewhere in the body. We've had probably about a dozen patients now where we found lymph nodes in what's called the left supraclavicular area. So above the clavicle, always on the left, never on the right, and nothing in between. And we've biopsied these all involved in prostate cancer. We do see this with other pelvic cancers, ovarian cancer, uterine cancer, where there could be a skip to an alternate lymphatic drainage to the chest right above the clavicle. So now we look for it. And we didn't really know to look for it as carefully as we did in the past. So it certainly changes the care for those patients. Looking at the bone, carbon acetate is also very good. The difference between this kind of scan and the sodium fluoride is this is looking at the prostate cancer cells in the bone, not looking at what the prostate cancer cells are doing to the bone, which is the other scan. So the changes to the matrix in the bone that the cancer causes, we pick that up with a calcium seeker, like sodium fluoride. This is actually looking at the cells that are prostate cancer. And so pretty small lesion here in a upper lumbar area, nothing anywhere else. This gentleman decided to have this radiated, but we didn't see this on any other scan as far as the traditional scans, and it very much changed his course of treatment. Also, just as far as where he is, at the time we did this, his PSA was 3 and doubling time of 3 months. Okay, here's another example. This is a gentleman who had a prostatectomy 9 years previously. His PSA was now coming up 4.8, fairly high, very quick doubling time. And again, he was also scheduled for a salvage radiation therapy to his pelvis, to the prostate. And we found a bone lesion in the second cervical vertebra, so up in the neck, sitting along the side here. Nothing anywhere else. This was confirmed by MRI and also biopsy. and the plan shifted from radiating down here to radiating up here. PSA and follow-up dropped very quickly. Okay. All right, so another example here. This is, when we talk about the bone scan versus the carbon acetate, at this point I use both of these scans together. And the rationale is that the F18 sodium fluoride bone scan can see very, very tiny areas of changes to the bone that might be caused by only a small amount of prostate cancer cells that I'm never going to see with anything. MRI, carbon, acetate, carbon colon, just not enough there as far as cancer cells to see, but they're leaving a trail. And so the bone scan can be very good for that. But there are occasions where there's a lot of going on in the bone marrow as far as cancer cells, but they haven't caused any changes to the bone yet that we can pick up. So this is an example where we did a sodium fluoride one day. This is the carbon acetate the next day, looking at the pelvis. It's lighting up here on the sodium fluoride. This is right at the end of the bone, right at the joint. So this is arthritic changes. Otherwise, it looks pretty good. Two very clear lesions in the bone marrow on the carbon acetate. So these are prostate cancer that have not yet caused any changes. So we're catching this about as early as we possibly can. Okay, and his PSA was quite high, so 43. And so I find these to be complementary. Okay, one of the other things that we've been fortunate to be able to figure out, we didn't invent carbon acetate. Carbon acetate has been used in the United States as a cardiac agent for probably almost 3 decades. The Italians use carbon acetate, carbon choline routinely. They're just way ahead of us on these things. One of the issues when we do any kind of imaging is trying to figure out the right protocol. Because injecting the agent, a certain amount of the agent is important, but also knowing when to image. Because we know that there's biology, metabolism that's going on, and we had a very difficult time when we were trying to figure out at what time point to image these patients after injection. We looked at the literature, and it was all over the map. So we did a small study to look to see when that's kind of the imaging timing sweet spot was. And we found that it was early. And I'll show you the next slide, which kind of shows the variability of the scan and when you try to correct for that. But essentially, small set of patients, we did the injection, we did an image right after we did the injection, then we redid the images at 20 to 40 minutes later and compared the results. And what we're looking for is, could I see the lesions better? PET imaging has the ability to quantitate, so I get a numeric measurement of how much metabolism is in an area and compare that to the background. So we could do some very strict quantitation to see if there was really a difference. So we did find that it mattered. So here's an example. This is another gentleman. We're looking at the pelvis here. This is the right side of the pelvis, and there's quite a bright lesion here that's in the bone marrow. This is the early imaging. This is the same patient 20 minutes later. Now you can still see this lesion, but the difference in the ability to see that and detect it is quite significant. Now, so for this particular lesion in this patient, at 20 minutes I wouldn't have missed this. I still would have called this. But the question is, if there were some more subtle lesions in the early one that looked like this to start with, they'd be gone by 20 minutes. So we just see a washout phenomenon. Okay, so when we take that information and we look at other people who have studied carbon acetate, a lot of relatively small studies going back to 2002, and when we did 2 things, corrected for the PSA levels, because we know any of these agents, the higher the PSA, the more successful they are, because we're tracking metabolism, and a PSA is a surrogate for metabolism in these cells. They're making a protein. And so when we corrected for the level of PSA and also the timing of when they did the imaging, the red are those that were done with early as opposed to the less. You see that the numbers start looking much more similar than different. If you look through the whole gamut of these, you're down at 55% here to 100%. That's a really wide range of detection rates. So in this particular one, these are all patients who had documented bone lesions by technetium bone scan. The expectation was 100%. You can see the PSAs range from 6 to 2,000, so, and a very small number. So 100% was very much expected. So we've been able to work out just the protocol that's going to be more consistent. So this is some analysis that we've done at the beginning of this year. As Russ mentioned, we're now quite over 500 patients that have been studied with this agent. But at certain points, we stop, we collect all the statistics and try to crunch the numbers. And we have done this all along this protocol just to see if our statistics have changed over time. And they have a little bit. I think if you can remember the numbers I presented last time, our overall detection rate was probably a little lower, and our subgroup analysis was a little bit different, but not too much. So with 370 cases we've analyzed, the range of the PSA is 0.2 to 148. The mean is about 6.9. The median is a little bit lower at about 2.3. And we take everybody, put them all together. How often was this a positive test? It was 87%. When we break that down to the different PSA levels when we did the imaging, greater than 1, this is at 90%, and you can see as we go down to lower levels, it drops off. Probably at this level here, 0.2 to 0.4, 50%, not a good enough test to do. So we've pretty much shifted to waiting until the PSA is around 0.4, 0.5. When we get up to about 70% or higher, we feel that that's a worthwhile test to do. Not that we aren't doing patients in this range, we still do a few of them because we want to have the numbers. And as long as everyone understands what the results are likely to be. One of the things with imaging we have to be careful about is just saying the image is positive, I see it there, detection rate. It's a good thing, but it's not enough. We really need to know how often were we right. And that's really the measure of these tests. Can be very difficult to achieve that, particularly with imaging. We've really looked at 3 things. We've looked at biopsy results, so after the imaging, to see an area we've identified, if it's biopsy positive or not. Other imaging, so down the line, whether a bone scan or MRI became positive in where we were expecting it to, or a Doppler ultrasound if it was in the gland area. And also in those patients who had radiation therapy to the areas we identified and no other therapy. This is a very small group early on where the radiation was only directed to the area that we identified. If it was one lymph node, it was one lymph node. And overall, when we take this, 38 out of 41 biopsies have been positive. Imaging has been very concordant, so almost 100%. And for the radiation therapy, what we looked for is a drop of PSA of at least 50% of where we started to count those as being positive. So very good numbers. We also had a set of patients where we called true negative because we started off with a fairly low PSA, and when we measured the PSA at the time of the study, they'd actually been going down, not up. So they didn't meet our definition of actually having recurrence because their PSA was going down. It was probably another reason for their PSA having elevated, either an infection or some other process going on. So when we put all those numbers together, TP is true positive, FP is false positives, and what we're looking for is what's called a positive predictive value, and it comes out to 94%. That's about as good a number as we could get for most imaging. So we're very, very pleased to see that. Okay, so we talked a little bit about doubling time, and when we break it down by doubling time, we wanted to see if the doubling time itself really influenced the detection rate on the scans. And we can see that the PSA was greater than 1, the doubling time was less than 10 months, 90%. Kind of the opposite of that, low PSA, so less than 1, with a higher doubling time, 67%. So quite a big difference. So we know that particularly when we're dealing with a PSA that's less than 1, we want the doubling time to be a little higher. So if I have someone who comes to me and says, my PSA is 0.5, and it's a 25-month doubling time, we're going to wait. I think it's not a good enough test to do at that point. And we could have broken this down by 3 months, 6 months, 9 months, 12 months. However, I think as a group of a number of different people working on this problem, we've decided to use 10 months for consistent reporting because we can't compare someone's results at 6 months to results at 10 months. And so we're trying to put our numbers in something that is much more comparable. Okay, so the other question I've been asked quite frequently with these is, where do we find these lesions? Are we finding them mostly in one area or another, or are they all over the place? And what's interesting remember the patients that we're dealing with here are patients who are having a recurrence. that have generally been negative on other imaging studies. So we do have some people with small equivocal things on other imaging studies, or something quite positive on another imaging study, but there was only one thing, and we were asked to look to see if there were other things. But generally, most patients in this population have negative imaging and a rising PSA. So we found that 28% are in the bed or in the prostate if the prostate is still intact, about 24% in pelvic lymph nodes. So it makes up about half of it that we're finding intrapelvic disease. So it's still in the pelvis. When we break that down by whether the patient had a prostatectomy, radiation therapy, or both, it's pretty even. In this patient population here, or I should say this ones with positive lymph nodes, most of these patients actually had already had prostatectomy and radiation to the prostate bed. So more likely we're going to find something in the nodes because we've pretty much wiped out everything in the prostate bed. We found about 8% of the patients had both, so something in the bed and also the lymph nodes. In the abdomen alone, so higher up than the pelvis, fairly small number. And about 30% in bone, with 21% of those only finding things in the bone, and about 9% finding it in the bone as well as in the soft tissues. So 2/3 are really falling into inside the pelvis. Other, that accounts for the supraclavicular nodes, lung lesions. We found one or two liver and pancreatic lesions as well. Pretty unusual to see those. Okay, and also when we looked at how often do we see something in the bone, and whether the doubling time or the PSA kind of mattered the most is determining that. And kind of as we would expect, a short doubling time, so PSA that's moving quickly, is telling us there's a higher likelihood that it's in the bone. But it's not 100%. So even doubling time of less than 3 months, 40% of the time we did not see anything in the bone. And that's, I think, really the take-home message is on here, that even with a rapidly rising PSA, doesn't necessarily, and we can't find out on the standard bone scan, doesn't necessarily mean it's hiding in the bone. So we probably need to look for it. And you can see as we go higher up, as far as doubling time, that drops off significantly. When we look at the actual PSA, that really didn't influence a whole lot. Actually, higher PSA in this patient population wasn't a harbinger of bone disease. Again, we've selected these patients out. Most of them have had negative bone scans, negative CTs. So those that had very high PSAs, we probably pick them up on the standard imaging. Okay. All right, so this is a comparison just looking at the different PSA levels comparing acetate to choline. So we broke this data up the same and presented the same way that Mayo Clinic did for their FDA approval. I know it's very difficult to read, but very low PSAs here, 0 to 0.4, 0.4 to 1, 1 to 2, 2 to 3, 3 to 5, 5 to 10, greater than 10. And just the percentage of positivity or detection rate. The blue is the acetate, the topotan is the choline. And when we get to 3 or above 3, these are pretty much the same. There's not a lot of difference in the detection rate. Where we're seeing, I think, the biggest difference is in the lower PSAs, probably anywhere from a 15 to 20% higher detection rate. And even particularly in the very low area, acetate is a lot better than choline, but this is probably not good enough even for acetate. So it's one of those things when someone is asking me also, and I've got a PSA of 0.5 and doubling time is 4 months, should I get a choline or an acetate? In the past, I would say it probably doesn't matter. I think the data is showing that the acetate is more likely to find this. So that's probably the recommendation at this point. Okay, so we talked a little bit about those patients who had spot radiation to some lymph nodes or other areas that we've identified. I think one of the questions that comes from that is, so we radiate an area that we see, we don't do any other therapy, how good is it? How long does the PSA stay down? How often do we actually see it work? And this is works in progress. Prostate cancer is a disease that we need to really track for 5 or 10 years to get any kind of really good long-term data on. And we're 2.5, 3 years in, so showing you some early data. So those 33 patients who had radiation therapy isolated to an area in the bed or pelvic nodes, no other treatment, we did see 28, so 85% of those had response. And our last follow-up in these patients out to 2 years, 24 of them have remained low, so have not had what we're calling a PSA recurrence. So that's actually quite good at this point. I suspect this number will drift down to a lower number. I don't know where it's going to be in 3, 4, or 5 years. That's going to be our task to look at this. And part of that is to put it in perspective when we compare that to what we do as a standard of therapy. So right now for salvage radiation therapy, so a rising PSA after prostatectomy to the prostate bed, when the PSA is less than 0.5, the chance that that's going to be successful long term, so 5 years or greater, is about 40%. So I can't quite compare these yet because of the time difference, but it's very encouraging. And we know that when the PSA is higher than 0.5, this number drops down to about 20%. And now, radiation oncology techniques are better, more precise, and this number might actually be much better today, but it's hard to get that information since we need to look at today's technology and follow people for 5 to 10 years to really see where we are. Okay, so this is my last slide. I think what I'm trying to convey here is that a combination of the sodium fluoride bone scans and carbon acetate study are very good, very high positive predictive values for finding sites of recurrences or metastases in patients with recurrence. One of the interesting things that we found is that the vast majority of these patients actually have intrapelvic disease, so up to almost 60%. And those are the patients that we can provide other options, additional radiation, additional surgery, cryotherapy. When it's in the pelvis, it's still, even though it may be out of the gland, it's still relatively lower risk disease than if it's outside of the pelvis. And so we're able to really select out the patients who we can offer additional therapy. Now, the carbon acetate, as I mentioned, very convenient from its very short half-life. So what we are hopeful for is an agent that performs like carbon acetate, labeled with F18 label instead, and FACDC seems to be a reasonable contender. We're going to be watching this one very closely, and I'm hoping to be doing some clinical trials, if it's not fast-tracked, pretty quickly within a year. So getting it from where it is today to commercial use in a year, year and a half would be phenomenal for an FDA kind of process. But the work we've done, the work that Mayo has done, has really pushed people to get more aggressive and see that we get an agent that is usable and easily held. Our clinical trials that we have open, you can find us on the clinical trials website, and I can leave this slide up afterwards if you want the numbers. Just goes into some details. One clinical trial is for relapsing or recurrent PSA after prostatectomy, radiation, or other definitive therapy. And we do have another trial that we have been enrolling in for patients who are before surgery, after surgery, before radiation, much earlier in the process of their therapy, to see how carbon acetate might help us decide on the best therapy for the patient. Okay. Any questions I can answer?
Okay, if you have any questions for Dr. Almeida, please raise your hand, and I will give you the mic. The reason I want to give you the mic is because we are recording this, and that's the way that we can hear it on the recording afterwards. So, yes, Marty.
I have a patient who went to the Mayo Clinic and had a post-RP, post-pelvic radiation, including the lymph nodes, when he had his recurrence, and then continued to go up. He probably was at about 0.8 or 1 when he went to the Mayo. They had a positive study, and then they did surgery, and the lymph nodes were negative, and his PSA is continuing to go up.
So they had a false positive.
Yeah, so he's still failing. He's not that far up the PSA ladder. Should he come and see you for an acetate study?
Yeah, well, or another carbon acetate. One of the things that we do see negative studies at low PSAs, or I'll see something that I'm not comfortable calling. So it's not quite positive enough. And part of the way I use these scans is I really look carefully through all of the structures, make sure that I'm not missing something, anything in the bone, the lungs. We scan the brain, just make sure we're not totally missing the boat. And I try to clear the whole body. And if I can't find anything with these studies when the PSA is very low, I feel safe that we can watch the PSA. Now, obviously, it's a personal choice. Some people will be very anxious about watching the PSA. But if anatomically I cannot find anything, metabolically I cannot find anything, we're looking at very minute microscopic disease. And if we want to treat it with some focal therapy, we have to wait for it to show itself. That's been a pretty effective course for us. Usually it's patients with very low PSAs. Although I do have a handful of patients with very high PSAs, relative 10 or 20, actually one who's got an 80. We've imaged him 3 times. Cannot find it. His metabolism of acetate is different. So that's part of nature. Not everybody is the same. There are going to be some biologic differences. But in him also, we haven't been able to find anything anatomically, so we feel safe in continuing to watch it. False positives, we have seen some. I have not seen anything related to inflammation per se. I think there's a tendency to overcall, for those who are doing this, the inguinal lymph nodes. So the lymph nodes on the outside of the pelvis, very rarely involved with prostate cancer, and usually only after someone's had multiple surgeries where we change the lymphatic flow. And I do see those by other people called positive when they're, to my eye, I would be calling them normal. Carbon choline has a little bit more activity in the urine, so there's some of it that does go into the urine, and it can cause some issues with interpretation down by the apical portion of the prostate when the prostate's been removed. So technique as far as the difference of what they're doing in Mayo, they are combining it with MRI. So they do a pelvic MRI and then combine it with the carbon choline. They do a very low dose CT, so anatomically more difficult to read. And so I can't explain why they thought there was a positive node, but that can happen. But I think the rates of false positive, even with choline in Mayo's hands and certainly in ours, have been very low. And so something we have to watch out for. One other thing just to comment on, these agents, particularly acetate, very avid with lymphoma. So other cancers. So I have made diagnosis of colon cancer, a couple of lymphomas, and a few other cancers, one brain cancer, for example. And part of it is looking at the imaging, does it make sense for distribution of prostate cancer? And for the most part with lymphoma, I'll see big lymph nodes in the inguinal area, the groin area, in the armpits, and high up in the neck, and places that prostate cancer very rarely goes. And if I see something like that, I have a very low threshold for, say, before we treat it, we need to biopsy it. We need to know what we're dealing with.
What would you do with this patient?
What's this PSA now?
It's like 1.8.
Yeah,
The doubling time is not as slow, not as rapid as what you're. But his PSA keeps going up.
Usually, if I have a negative study, I wait until the PSA is at least doubled from where I imaged before. So he would be in a good position to have looked at again.
What PSA should I?
The 1.8 to, you said 0.8 before, so he's already passed the double on that. What I would suggest, if it's okay with you, send me the scan. Let's take a look at the choline and have a second look. So let's take a look back at the original imaging and see if there was anything that potentially was missed before we do any more imaging. And so it's very good to have multiple imaging studies to look at, because 2 points of time are always better than one. But probably right time to do it again.
Okay, before I go to the next question, just let me tell the audience what happened here. We have 2 doctors discussing one patient. So you can understand, 2 doctors never agree on anything. So they're going back and forth there. Actually, Marty does agree there. I just was making a little joke.
I'm not a doctor.
So that means you know more about prostate cancer than us, both of us combined, right?
But I heard you describe the difference between sodium fluoride and carbon acetate. That's just hold it in your mouth.
All right, can you hear me now?
Yeah.
Can you hear me? Anyway, the difference between sodium fluoride and carbon acetate, you said that in order to be complementary, you would do one slide one day and one the next day. Was that a figure of speech or?
If someone comes to me not having had a sodium fluoride bone scan, I'll want one done. And for the most patients that are coming to see me, it's convenient for us to do these back to back. But if you have a sodium fluoride scan locally, then I say, please, I want to look at it to compare it to. So I want the information. Sodium fluorides are done all over the country. There is a quality difference I see from place to place, but I think in general, it's good quality, and I'll bring those results in. I want to see it. Because part of it is I want to make sure if there was anything that was equivocal on it, that it was called equivocal, that we try to use the carbon acetate to help complement and problem solve. In a few patients, and this is an interesting nuance, Medicare pays for sodium fluoride bone scans universally through what's called the National Oncologic Registry Program, NOPR. So always pay for it. If you're under 65, private insurers don't pay for the sodium fluoride about 50% of the time. So my younger patients, often we won't do the bone scan until we've done the carbon acetate. So we'll do the carbon acetate. If there's anything at all suspicious in the bone, or if it's a negative study in the carbon acetate, but they have suspicious PSA, the risk factors are high, I'll suggest in the report that they get the sodium fluoride to kind of push the insurers along a little bit to get it.
Okay, I guess my question would be, and you didn't mention the amount of radiation. And I think in your presentation here, how much radiation can a body, would you expect?
So that question has become much more relevant in the last couple of years. Particularly in California, I think now there's a requirement to report the exposure rate on a CT scan of everybody. My personal opinion, first off, is it is gone way too far as our need to be careful. Certainly we have to be careful. We don't want to do any kind of imaging, CT scanning or PET scanning unnecessarily, and we don't do these things every week. These typically have between 16 and 30 millisieverts as a unit of measure of radiation. Quite much higher than a chest x-ray, but a minuscule amount compared to the radiation we do to treat anything. So if you've had radiation therapy, for example, to the prostate bed, we're never ever going to trump that or exceed that with any kind of imaging. Part of it also, why are we concerned about all the radiation? Is because cumulative effects of radiation we know can cause issues. The main ones we're worried about are lymphomas and leukemias. They are something that they do happen, pretty low rates of it, but we're pretty sure they do happen. But it's something that happens within a decade or 2 decades. So you need to have a fair amount of radiation, and then 20 years later, we might be dealing with something else. The trade-off of doing a high-quality imaging study to get an answer versus doing a so-so imaging study with a lower dose that doesn't give you the answer that you're going to have to repeat often. And it doesn't make sense to me to do a low-quality, low-dose imaging study if it doesn't answer the question. And anyone with cancer is pretty much trumps the potential for having cancer later in life. So there's a balance. So we have the concept of imaging gently, where we can reduce the dose, where it makes sense. We try to do that. Our pediatric population, young women, we need to be much more careful, because you go into the emergency room, got a bump on the head, you're going to get a CT scan of the head. And that's part of what we're trying to slow that down, to be a little bit more cautious about over-imaging young populations who potentially, we're going to be doing that now with all this technology, they're going to have that 20, 30, 40 years of radiation exposure, and we're going to get them in trouble later.
I was interested in your outcome slide, and in my mind, when you are doing these imaging, you're taking a snapshot in time, and you see a tumor on the bone, or metastasis on the bone, and then we radiate it, and it goes away, but you still got prostate cancer cells in your body, and they can attach to a bone somewhere else, I would assume. So, and just to follow this up, now I had a prostatectomy and then radiation to the prostate bed. After the radiation to the prostate bed, I was undetectable for 2 years, and then my PSA started going back up again. So is it the same type of thing that you anticipate, but you've only had a couple of years?
I think no imaging technology is going to show us microscopic disease. So if there is something circulating in the blood or elsewhere in the bone that's minuscule, like just a few cells, we aren't going to be able to see that. Part of this is what are we accomplishing by finding these areas that potentially we can treat? And I think what it comes down to is the vast majority of men are not real excited about going on hormone therapy. And so hormone therapy works, but it comes with its side effects and issues. And so part of the strategy is, can we delay that? So someone with a bony lesion, if we're radiating it, we're trying to get rid of the bulk of the disease or the disease that might then shed to other areas. And we know very well there's a good chance that there's going to be some small disease elsewhere, but it might take many years for that to develop into something that we can detect with the PSA or that otherwise is relevant. And if we've pushed off systemic therapy for a period of time, I think most people are happy to do that. If I have a patient who tells me, well, I'm going to have the scan, but regardless, I'm going on hormone therapy, I say, well, why are we doing this? Because I'm not going to give you any information that's going to change what you do. So the whole idea is information. If we find limited disease, is it an option to go after it? And what are the expectations of, are we going to cure it, get rid of it entirely? Some people we might. Most probably not. We're really just pushing this into hopefully a more chronic problem rather than something that's going to be progressing.
So then how would you address someone like myself that is past the hormone therapy, that is castrate resistant, and now we're kind of in that thing of watching the PSA develop, you know, it doesn't show in the normal scans. Where are we at?
I have a number of gentlemen like you. I think part of the goal of the imaging is, can we find a culprit lesion? So you might have multiple lesions that you've had, they've been treated, and you have one or two pesky lesions that are not responding to the hormone therapy. Are they in locations that can be radiated such that we get your PSA down and give you an opportunity to be on a longer holiday? So that is really what we're going for, is extending the life of the hormone therapy and also understanding where these lesions are, because if I find, for example, and I found this in many people who have been on hormone therapy, chemotherapy, Zytiga, Xtandi, Taxotere, everything. Never had any imaging evidence of disease, but the PSA, if they stop treatment, it just starts to roar. Do the imaging, I find a seminal vesicle that's 1.5 centimeters and it's just blazing. And it's been there for however many years, and we've hit it with all of these things unsuccessfully. Well, that's a lesion that we have an alternative that we can get rid of. And I've seen a number of those where we find something that's very treatable. The other is context. I go through these imaging studies with everybody personally, run through them, so I want people to understand what we see. And if I see one little bone lesion or one little lymph node, and even if they're putting on a lot of PSA, understanding where your disease is and where your disease isn't, I think it's important as you get up every morning and go, well, okay, that's kind of stiff. Is it prostate cancer, or is it just because I slept funny? And a lot of sports injuries that never go away. I've got mine, and overlapping. How do you tell? Well, that's just my body versus this might be actually something I need to be concerned about. And so getting the context, even if the therapy is going to be the same, understanding what you're treating, I think can be important. Not everybody needs to know that, but I find a lot of people that's helpful information for them to understand their disease.
Anybody else? Okay, here we go.
Is carbon acetate, does Medicare pay for it?
Does not. So right now it's being done at our facility under a clinical trial, also in Kansas University under a clinical trial. And both of our centers, we have a lot of support funding, but it doesn't cover it all. So the reality of today is $3,000 at our facility. Kansas University does it for 3,000, unless you say, well, I could go to Arizona, then we'll drop it down to 2,500. And we'll do the same thing. Part of it is not to be competitive, but that's, that's part of it, is competition. That's a good thing, and I'd like this to be free, but we have a gap that we have to cover to make it happen. And but ultimately, we're gonna drive the price down quite a bit, because it's a necessary test, I think, or something like it, and it needs to be affordable.
So you're in the desert here? You're here in California now?
I was in Indian Wells for a number of years. I'm not in Indian Wells, and that's a standard imaging center that was there, not our facility that can do the carbon acetate. So carbon acetate is only done in Phoenix at our research facility there. So we're right by the airport. It's easy to get to. It's a long day, but
That's a discount. It's easier to get to than Minneapolis, Minnesota, right, or Rochester, Minnesota.
Well, see, it depends if you're a cold weather person or a hot weather person. So this time of year,
How
Minnesota
about
sounds
Florida?
a lot better than
How about
Phoenix.
the Fahrenheit scan in Florida?
Yeah, there you go. So we tend to have a surge around January because everybody from the Midwest and the North want to come to Phoenix. So.
Oh, Ron, you have a question?
Now, how long do you have to be in your area or the facility to do this test?
So the C11 itself, the actual imaging is 20 minutes. And so everything leading up to it and after it is prep, and then also discussion about going over the results. Because this is a fairly significant undertaking for us, I don't only do this when I only have one patient. I have multiple patients that we do together. So everybody's got to be there. So we don't start our process until everyone shows up. And because even a little bit of a delay will be a problem. So typical days, we have people come in at about 9 o'clock. We usually have them done with imaging before noon, and they're out of the clinic by 1 or 2 o'clock after having as much time they need with me. That's if everything goes perfectly. If someone needs to have a bone scan, we do the bone scan the day before. That's a very routine scan. So you come in, get the injections, 45 minutes waiting time, let it circulate, 20 minutes on the camera. No real significant preparation for either of these, no dietary restrictions. The only thing we ask people to do that is of consequence is I ask people not to do any heavy exertion 3 days before the carbon acetate. Muscles are very good at using acetate as an energy source. And I've had a few people go play around with golf before they came in, and all I saw were their shoulders and legs. So that's something we learned over time, is to have people just kind of take it easy for a couple of days beforehand.
Anybody else before I let them go? Okay. Dr. Almeida, we sure do appreciate you coming here. Thank you very much. As you all know, well, I only have 2 hands. Just hold on to that for a minute. There is no off button.
I'll just stand here.
Carson has the off button up there. As you all know, we can't really afford, with our budget, to pay these doctors a great deal of money.
Now I have a pair.
Yeah, so we gave them one of these last year. This is to put in your car. It has the holder so that you can save time. Time is money, right? Time is money. So now he has a pair. He can give one to his wife.
There you go. Mine doesn't help.
Thank you very much, Doctor.